How can we treat anxiety disorders in patients with cancer? Similarly to the treatment of depressive disorders, anxiety disorders can be effectively treated with different forms of psychotherapy, particularly cognitive behavioral therapy, but also by implementing and teaching patients techniques like relaxation or problem-solving therapy. For some conditions, hypnosis can be very helpful. As far as pharmacological treatment, the first-line treatment of anxiety involves antidepressants, so SSRIs, SNRIs, or mirtazapine. For some patients, concomitant use of benzodiazepines can be very helpful, particularly initially, while we're waiting for the effect of antidepressants. Benzodiazepines can be helpful for patients who have significant acute anxiety or a panic disorder. They are relatively widely used in cancer patients. I, in my practice, tend to lean on lorazepam or clonazepam, and I always prefer to use them only on an as-needed basis. Very rarely do I use any of these drugs routinely, and if so, only for a short period of time, and only for patients who are not exhibiting any signs of delirium. We need to keep in mind the potential side effects of benzodiazepines, such as oversedation, drowsiness, ataxia, and precipitating or worsening of delirium. We want to be particularly careful about using benzodiazepines in patients who are elderly. Antipsychotic medications such as quetiapine or olanzapine do not have an FDA approval for treatment of anxiety, but at low doses they may be helpful in patients who are both anxious and confused, so likely delirious. They can also be useful in patients with respiratory complications, as antipsychotics do not cause respiratory depression. As I mentioned earlier, many of our patients struggle with fear of becoming addicted to psychiatric medications. And here, education about the purpose of medications, how they work, and what it means to take them is very important. When approaching patients with depression or anxiety, or both, because many of our patients do present with both depression and anxiety, I would recommend that we approach each patient with a good dose of cultural humility. We know that patients who come from non-majority groups tend to report less satisfaction with treatment, less shared decision-making, and less overall trust of their providers. We know that disparity can be exacerbated by racial, ethnic, or linguistic discordance between patient and the doctor, and also by patients' past experiences of discrimination. There is still a lot of stigma in seeking psychiatric care, particularly in certain groups. Although depression is a well-accepted concept in European and North American cultures, in many non-European cultures, it's hard to find the equivalent concept. And in many cultures, it is actually part of a normative presentation that patients present more with physical symptoms. They may underreport emotional, cognitive symptoms of depression. And that may lead also to a lack of motivation to receive sort of a standard Western psychiatric treatment. In some cultures, in some ethnic groups, somatization, so presentation with somatic symptoms, can actually be more acceptable. Many of our patients who come to us or who are meeting with their oncologist who may suggest to go and see a psychiatrist may fear that if they do, they're going to be labeled, quote unquote, crazy, that there is something really wrong with them. And we want to address that, and we want to reassure them that we want to help them, and our goal is to decrease their suffering. In conclusion, primary anxiety disorders, for example, generalized anxiety disorder or panic disorder, are usually treated with antidepressants. Benzodiazepines should ideally be used only for short-term and on an as-needed basis. And other modalities of treatment, such as cognitive behavioral therapy or hypnosis, can also be very effective interventions for anxiety.